LinkedIn is great at connecting you with the world's largest professional network. But it can't connect you with motivation on a Monday morning. LinkedIn can help you get insights from your professional community. But it can't give you any insight into why Dave's still talking on mute. And while it can't stop your boss from bringing tuna for lunch, LinkedIn can help bring your career to the next level. LinkedIn is the network that works for you. Visit LinkedIn.com to learn more.
Hey everyone, Chris here from MedPrep to Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 Questions podcast combined and ad-free. You'll also get early access to all of our Step 2 Questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com. Hey everyone, Chris here from MedPrep to Go, and welcome to another episode of our USMLE Step 2 Questions podcast. In this episode, I'll be reading 3 ophthalmology questions from our online Qbank, and as always, you can read these questions and more at medprep2go.com. And let's get started with question 1, Ophthalmology 4. A 10-day-old male infant is brought to the pediatrician by his mother because of bilateral eye redness and discharge for the past day. The infant was born at home via spontaneous vaginal delivery to a mother who received limited prenatal care. The infant's temperature is 37.2 degrees Celsius or 99 degrees Fahrenheit. On physical examination, the eyelids are significantly edematous and the palpebral conjunctivae appear thickened and erythematous. There is a moderate amount of watery, mucopurulent discharge from both eyes. No corneal opacities are noted. The lungs are clear to auscultation. A Gram stain of the conjunctival scrapings shows no organisms, but a GEMSA stain reveals several intracellular inclusions. Which of the following is the most appropriate next step in the management of this patient? Is it A, intramuscular ceftriaxone, B, intravenous acyclovir, C, oral erythromycin, D, topical erythromycin, or E, topical silver nitrate? And the correct answer is C, oral erythromycin. The clinical presentation and the presence of intracellular inclusions on GEMSA stain are diagnostic of neonatal chlamydial conjunctivitis caused by Chlamydia trachomatis serotypes D through K. This typically presents 5 to 14 days after birth with eyelid swelling, chemosis, and mucopurulent discharge. Unlike many other forms of neonatal conjunctivitis, chlamydial infection requires oral macrolide therapy, for example, erythromycin or azithromycin. Systemic treatment is necessary because topical therapy has high failure rates and, more importantly, because these infants are at high risk for developing chlamydial pneumonia. When using oral erythromycin in neonates, clinicians must monitor for the potential side effect of infantile hypertrophic pyloric stenosis. Answer choice A, intramuscular ceftriaxone, is incorrect. This is the treatment of choice for gonococcal conjunctivitis caused by Neisseria gonorrhoeae. Gonococcal conjunctivitis usually presents more acutely, typically 2 to 5 days after birth, and is characterized by significantly more profuse purulent discharge and the risk of corneal perforation. Gram stain would show gram-negative diplococci. Answer choice B, intravenous acyclovir, is incorrect. This is used for neonatal herpes simplex virus, HSV, infections. HSV conjunctivitis typically presents within the first 2 weeks of life and is often associated with vesicular skin lesions, keratitis, or systemic involvement. Answer choice D, topical erythromycin, is incorrect. Topical erythromycin ointment is the standard prophylaxis administered to all newborns shortly after birth to prevent gonococcal ophthalmia neonatorum. However, it is not an effective treatment for an active chlamydial infection, nor does it reliably prevent chlamydial conjunctivitis. Answer choice E, topical silver nitrate, is incorrect. Silver nitrate was historically used for gonococcal prophylaxis, but can cause chemical conjunctivitis. Chemical conjunctivitis typically presents within the first 24 hours of life and is characterized by mild conjunctival injection and tearing that resolves spontaneously. Key learning point. Neonatal chlamydial conjunctivitis typically presents 5 to 14 days after birth with mucopurulent discharge and chemosis. Diagnosis is confirmed by a nucleic acid test, NAT, or the presence of cytoplasmic inclusions on GEMSA-stained scrapings. The most appropriate management is oral macrolide therapy to treat the ocular infection and prevent the development of chlamydial pneumonia. Question 2, Ophthalmology 5. A 28-year-old man comes to the physician because of a 2-day history of redness, pain, and blurred vision in his right eye. He also reports significant sensitivity to light. He has a history of intermittent low back pain and stiffness that is worse in the morning and improves with activity. Physical examination of the right eye shows circumcorneal injection, ciliary flush, and a constricted irregular pupil. Slit lamp examination reveals a flare and cells in the anterior chamber. The rest of the physical examination is notable for limited forward flexion of the lumbar spine and tenderness of the sacroiliac joints. Which of the following is the most appropriate next step in the management of this patient's ocular condition? Is it A, atropine drops, B, intravenous acyclovir, C, intravenous methylprednisolone, D, topical ciprofloxacin, or E, topical prednisolone? And the correct answer is E, topical prednisolone. The patient is presenting with acute anterior uveitis, iritis, characterized by painful red eye, photophobia, ciliary flush, in the presence of leukocytes and protein, cells and flare, in the anterior chamber. His history of inflammatory back pain and limited spinal mobility is highly suggestive of ankylosing spondylitis and HLA-B27-associated spondyloarthropathy. Acute anterior uveitis is the most common extra-articular manifestation of these conditions. The primary treatment for non-infectious anterior uveitis is topical corticosteroids such as topical prednisolone to reduce ocular inflammation and prevent complications like vision loss. Answer choice A, atropine drops, is incorrect. Atropine is a cycloplegic agent used in the management of uveitis to dilate the pupil, prevent the formation of synechia, adhesions, and relieve pain caused by ciliary muscle spasm. While it is an important adjunctive therapy, topical corticosteroids are the definitive next step to treat the underlying inflammatory process. Answer choice B, intravenous acyclovir, is incorrect. Intravenous or oral acyclovir is used for viral uveitis or keratitis, often caused by herpes simplex virus or varicella zoster virus. Viral etiology is usually suggested by the presence of vesicular skin lesions or dendritic corneal ulcers, whereas this patient's systemic symptoms point toward an autoimmune or inflammatory cause. Answer choice C, intravenous methylprednisolone, is incorrect. Systemic high-dose corticosteroids are reserved for severe, sight-threatening ocular inflammation such as optic neuritis or severe posterior uveitis. Uncomplicated acute anterior uveitis is typically managed with topical therapy rather than systemic intervention. Answer choice D, topical ciprofloxacin, is incorrect. Topical antibiotics are indicated for bacterial conjunctivitis or bacterial keratitis. Bacterial conjunctivitis typically presents with purulent discharge and lacks the deep-seated pain, photophobia, or anterior chamber findings seen in this patient. Key learning point: acute anterior uveitis, iritis, presents with a painful red eye, photophobia, and cells and flare on slit lamp examination. It is strongly associated with HLA-B27 positive conditions like ankylosing spondylitis and reactive arthritis. Management involves topical corticosteroids to reduce inflammation and topical cycloplegics to prevent synechia and manage pain. Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We'd greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable. Hey everyone, Chris here from MedPrep2Go, and I wanted to tell you about our MedPrep2Go Step 3 review podcast that features over 90 episodes and 40 hours of high-yield content from Dr. Ted O'Connell and Dr. Raj Dasgupta. This is a premium podcast that has already helped over 100 students pass their exam. You can learn more and subscribe at medprep2go.com. Question 3, Ophthalmology 6. A 62-year-old woman is brought to the emergency department because of sudden, severe pain in her left eye and frontal headache that began 2 hours ago while she was watching a movie. She also reports several episodes of vomiting and seeing rainbow-colored halos around lights. Her medical history is significant only for farsightedness, for which she wears corrective lenses. On physical examination, her left eye is diffusely injected, the cornea appears hazy, and the pupil is mid-dilated and non-reactive to light. The globe feels firm to palpation compared to the right side. Which of the following is the most appropriate next step in the management of this patient? Is it A, intravenous mannitol, B, laser peripheral iridotomy, C, measurement of intraocular pressure, D, oral acetazolamide, or E, topical prednisolone? And the correct answer is C, measurement of intraocular pressure. This patient is presenting with a classic case of acute angle closure glaucoma, AACG. The combination of sudden eye pain, nausea, halos, and a mid-dilated non-reactive pupil is highly suggestive of this ophthalmologic emergency. While the clinical suspicion is high, the most appropriate next step to confirm the diagnosis is the measurement of intraocular pressure, IOP, via tonometry. In AACG, the IOP is typically significantly elevated, often greater than 50 mm per mercury. Rapid confirmation is essential because prolonged elevation of IOP can lead to irreversible optic nerve damage and permanent vision loss. Answer choice A, intravenous mannitol, is incorrect. Mannitol is an osmotic diuretic used to rapidly lower intraocular pressure, but is typically reserved as a second-line treatment when the IOP does not respond to initial medical therapy such as topical beta blockers, alpha agonists, or acetazolamide. Diagnosis should be confirmed before initiating such systemic therapy. Answer choice B, laser peripheral iridotomy, is incorrect. This is the definitive treatment for acute angle closure glaucoma as it creates a permanent opening in the iris to allow aqueous humor to bypass the pupil and enter the anterior chamber. However, it is performed once the acute attack has been medically stabilized and the corneal edema has cleared enough to allow visualization of the iris. Answer choice D, oral acetazolamide, is incorrect. Carbonic anhydrase inhibitors like acetazolamide are used in the acute medical management of glaucoma to decrease aqueous humor production. While often part of the initial treatment cocktail, the most appropriate next step in a patient presenting with these symptoms is to confirm the elevated IOP via tonometry. Answer choice E, topical prednisolone, is incorrect. Topical corticosteroids are used to treat inflammatory conditions of the eye, such as uveitis. While uveitis can present with a red, painful eye, it typically features a constricted or myotic pupil and cells in flare in the anterior chamber rather than the mid-dilated pupil and corneal haziness seen in AACG. Key learning point. Acute angle closure glaucoma is an ophthalmologic emergency characterized by sudden eye pain, headache, nausea, and halos around lights. Clinical signs include a mid-dilated, non-reactive pupil and a hazy cornea. The most appropriate next step in management is the measurement of intraocular pressure by tonometry. Once confirmed, treatment involves immediate pressure-lowering medications followed by definitive laser peripheral iridotomy. And that will conclude this episode of our USMLE Step 2 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. As always, you can learn more and read other Step 2 questions at medprep2go.com. Happy studying! Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics.